We can start it.
Shiba, you can start.
Yes. Good evening, everybody. Welcome of the international webinar, Global Trends in Mental Health, organized by Madras Christian College in collaboration with Commonwealth Organization for Social Work. Day one, we had speakers from Caribbean and Americas. Here is an overview of yesterday's session. The trends in global mental health, social work issues and practice during pandemic, and lessons from Caribbeans were discussed. We have two sessions for the day. Session 1 will be chaired by Dr. R. Srinivasamurthy with 4 speakers from Asia, followed by the second session chaired by Ms. Naomi Spencer with 2 speakers from Pacific. I request the chairperson to make a note of the timings of each speaker, the general instructions for the participants. The participants on the Zoom platform can post their questions in the Q&A box, and the participants watching it live on YouTube can post it in the chat box, which will be answered at the end of each session. Day 2 attendance will be posted in the chat box, both in Zoom and YouTube. Let's begin with the session 1, which will be chaired by Dr. Srinivasamurthy. Dr. Srinivasamurthy was awarded the Professor Lopez Award by the World Psychiatric Association in 2012. In 2016, Indian Council of Medical Research, New Delhi, awarded the Distinguished Scientist Chair of ICMR for the period of 5 years. Dr. Srinivasamurthy has been a short-term consultant to assist in the development of national programs of mental health in a number of developing countries. His areas of interest has been community mental health policy, disaster mental health, and intellectual disability. He has published extensively in national and international journals, over 250 publications. Dr. Murthy has authored over 10 manuals of mental health care for non-specialists and co-edited 5 books. Now, I request Dr. Srinivasamurthy to chair the session.
Thank you very much. It's been a pleasure to be with you all. Good afternoon. And it's a very, very special day because we are looking at the global trends in mental health. Yesterday was especially very good when we heard Dr. Miriam Samuel, David Jones, Gottfried Broken, Wilson, Dr. Ganesh, Prince Anadare, and speakers from Caribbean. The thing that impressed me most from yesterday's thing was the emphasis made by Dr. Jones about the importance of mental health in this present pandemic. Dr. Taylor was very, very good. As a very good background to today's session, she talked about community partnership, people's participation, and very importantly, human-centered approach and the opportunity this pandemic offers us to fight stigma about mental health. Very interestingly, Dr. Wilson talked about the value of using artificial intelligence. All of you are aware of it. But to me, more important was some of the comments in the chat box. I just want to read out 3 of them as a background to today's session. For example, Mr. Dhanush Sai said, people feeling low, how do I help them? Another speaker, Vinaya Mukesh, said, how to provide moral support. Another speaker, another participant said, Swagatika Samuel said, what do we do about migrants? It is in this context, mental health becomes very important. Because the word pandemic itself comes from 2 words, pan, all, it refers to all, Dema refers to people. So pandemic is one of all people. What we are trying to do in this session is to see how everyone can be part of the solution rather than part of the problem. And we also know that the pandemic is as much a social challenge as a medical challenge, as pointed out by the United Nations Secretary General Guterres in his recent speech in honor of Mandela. The three speakers we have today are, unfortunately, Mr. Ramesh could not join us because of his ill health. We wish him well. The first speaker is Sai Kumar. He is former head of the department of Vaishnav College, and is a practicing psychotherapist, innovator, popular speaker for professionals and lay persons. I have known him for more than 30 years from his student days, and I can truly say he is one of the most remarkable social workers that I have met in my professional life. He is full of energy, full of innovation, and always thinks out of the box. And we are looking forward to hear him speak about HRD challenges in India during the post-COVID era. Interestingly, you will be very interested to know just this morning, the Indian Journal of Psychiatry published a figure showing that at the point of lockdown, 40% of the people had either anxiety, depression, another 75% had low mood, as well as poor subjective well-being. If the numbers are going to be so big, we really need to think of human resource challenges in a very innovative manner. The second speaker will be Prince Aladure, Associate Professor of Madras Christian College, and all of you know him very well. He will be speaking on COVID-19 and mental health of the elderly. We are looking forward to it because elderly are at this pandemic level, like me, are especially vulnerable, and they experience the lockdown worse than other people. As I said, Ramesh will not be joining us. We wish him well. The third most important speaker is Dr. Teo. He is the chairperson of the Commonwealth Organization of Social Workers. He lives in Malaysia, and he will be speaking on Commonwealth Charter and social work's shared values for the profession. So without taking too much of time to introduce them in great detail, because of the limited time, I have requested them to tell us about them as part of the presentation. Each one of them will have 10 minutes presentation, one after the other. We'll take up the question answers and the comment section at the end of the thing, at the end of the 30 minutes. I am requesting each of the speaker to call upon the next speaker so that I don't come in and waste time in making the changes. I hope it's all right with the speakers. With this, I now invite Dr. Sai Kumar to speak on HRD challenges in India during the post-COVID period. Okay. I'm going to unmute and
Can you see the screen now, please?
Yes, sir.
Yes, yes.
Full screen, can you see?
Not the full screen. It's part of your mail or computer. I think you need to go for full screen mode.
1 minute, 1 minute. Can you see now?
Yes.
Yes, sir. Now it's full screen. Thank you.
Can I start?
Please go ahead, Dr. Sai.
Okay. Good afternoon to all of you. It's a pleasure to be amongst the stalwarts, and I'm very privileged to be with my teacher. And I would like to thank the Madras Christian College for giving me an opportunity to share some of the very important points related to the modern mental health care. And I wish to thank the chairperson for his nice words that he has given it on me. I hope that I'll be able to live up to the expectations of him as well as others. Dear friends, as the chairperson has pointed out, we are living amidst of a huge pandemic unknown to the history in the recent time, but still we are trying our best to cope up in our every possible way. And particularly, this pandemic has thrown up huge amount of challenges in the problems related to mental health. While we are quite comfortable or known to handle things, anything to do with the physical health, but then the large number of professionals are not very well equipped to deal with the mental health care. And that too during this time, as well as once the pandemic ends, how are we going to position ourselves in looking at the future of mental health care, and the way in which that we have been responding now will give us an idea about how we are going to do it in future. Now, in the next about another 8 minutes of my presentation, I hope to cover about how India has progressed in the mental health care, and how we have been struggling with the severe shortage of mental health manpower. And it is also very important for us to improve the human resource dimension of our mental health manpower and challenges that are associated with the post-COVID. And I would like to throw upon some light related to how the HRD is viewed in different levels of mental health system, particularly with reference to teamwork. And at the end of it, I give a few suggestions that may be considered by the audience as well as for the planners. Now, we know that mental health, mental disorders have got a profound implications to the well-being of individuals, families, and the entire communities, because it is affecting the ability to cope with the stress and productivity. In fact, if you see some of the very beautiful document that is written by, made by Dr. Agarwal, who reviewed the entire aspect of mental health in Indian perspective between the year 1946 to 2003, is giving you a lot of very good glimpse about many areas of mental health. So the projected global burden on mental health for us is from 11.5% in 1988 is jumping to 15.5% in 2020. Then we also have other issues along with mental health. When I say mental health, the popular conception is that severe mental disorders. We would like to remind the students as well as many others that there are also other issues related to mental health like alcohol and drug abuse, delinquent behavior, leading to impaired quality of life. That leads to inappropriate risk-taking behavior. And then it is coming to the patterns to contribute to the major public health problems. I also would like to mention the increasing number of suicide or attempted suicide rates comprising 1.6% of the global burden in 1998 is increasing now. The need for renewed vigor in the provision of community-based mental health care services in this context is very, very important. It assumes significance. In fact, we would like to just to give you an idea about the findings of National Mental Health Survey that was conducted by NIMHANS, which gives some very interesting figures. Earlier, we used to listen to the figures during the years 80s and 85, 90s and all that. Safely, we can consider 1% of the population as having a severe mental disorder. But this research has shown some very good findings. At least 13.7% of the India's general population has various types of mental disorder. It's an alarming figure. And 10.6% of them, they require immediate intervention. And 1 in every 20 people in India, they suffer from depression. So you can understand that how and what kind of challenges are laying ahead for us to offer care and services for them. It also shows some very interesting findings. What are they? The common mental health disorders, along with the comorbidities like substance abuse, are also a huge burden affecting nearly 10% of the population. Why it is very important? It is very important because India is committed for community-based approach. From the clinical approach, that is doctor seeing a patient in a small clinic and offering a service. Now we have graduated to the level with our commitment to the National Mental Health Policy, National Mental Health Program. Now we are adopting a community approach, and that needs a lot of changes and challenges in the services. That means the people who are manning those services need to be greatly oriented to the new shifting of the gear. So in that way, human resources assume a lot of significance. Now, I think I don't want to give these figures again. Already you had it. Now let me try to quickly get into the main topic of human resources and human resource development, how it is related to that. According to the World Health Organization, that human resources are the most valuable asset of a mental health service. In fact, such a service, it relies on the competence and motivation of its personnel to promote the mental health, prevent disorders, and provide care for the people with the mental disorders. So, by setting this stage, I would like to give you a glimpse of a manpower available, human resources available in our country with our mental health facilities, mental health care facilities, which is creating a huge gap in the services. In fact, if you see that we have got only 289 departments of psychiatry in medical colleges, and we have got only 30,000 psychiatric beds available, and 3,800 psychiatrists as against the requirement of 11,000 plus psychiatrists we need. We have got only 898 clinical psychologists as against 17,250. We have got only 850 psychiatric social workers as against 23,000 we need. Similarly, we can also correlate psychiatric nurses who are available only 1,500, but actually we need 3,000. There are many other figures. We will not go into that. We will get into the significance of this, why human resources are very important. World Health Organization has given many commandments, 10 commandments it has given. If you see the 7th commandment, it is developing human resource. What is the human resource development? In fact, I would like to tell you about Dr. T.V. Rao, who is known as the father of HRD in India. He says that it is a process by which the employees of an organization are helped in a continuous and planned manner to acquire and sharpen capabilities required to perform various functions associated with their present or expected future roles. But here we are talking about the present services and doctors and nurses and social workers and psychologists offering services now at the moment, and in future what kind of services they're going to offer. For example, all of us are involved in technology, using technology. Do we have skills for that? Now, in essence, he is talking about to develop the skills, knowledge, and abilities. So in summary, HRD means it is a framework to develop the set of skills, knowledge, abilities, which in turn improves organization's effectiveness. Now,
Sai, you have got two more.
With reference to mental health, it refers to recruitment, orientation, training, and development at one side. Another side, we are talking about efficiency, effectiveness, productivity, teamwork, changing roles of mental health programs, professionals, and creating positive work culture, etc. And in fact, as I told you earlier, that India has graduated from the time of earlier long back Lunacy Act 19 earlier time, and then now with a community mental health program 1982, where we have got 3 important objectives. When we are trying to meet these objectives, Green 1999 has specifically talked about human resource, where he says major difficulties which are frequently encountered in planning of their services is human resource. Why it is a problem? Because we don't have an appropriate body responsible for such planning, and we have got a lack of data. We do not know exactly the number of human resources, though we have got some figures. And high cost of mental health professionals. Training cost is quite high. There is a stigma among the professionals to join this course and continue this service. Now, HRD has got many interface in this aspect, but like for example, with the mental health professionals, we have to talk about the resources that are.
Sai, can you conclude? Already 10 minutes over.
Yes, just 2 minutes. Sir. Okay, sir. Okay. So with reference to the suggestions I would like to give, that the quality of human resources with the modern HRD approaches is possible, provided if we are able to use technology and modern resource methods. In government as well as professional bodies are not lagging behind. They have come into that by offering services in this pandemic time, and I hope that they will continue to do that. And whether we need to only find out whether these services are offered either in an efficient manner, effective manner, equitable, and accessible manner. For example, when you're talking about technology, is it available for large number of rural population? So by concluding, I would like to say the words of Pandya, and who says that quality of improvement in mental health programs is very important. Community-based mental health programs is very important. We need to gear up to the non-specialist care programs using mobile technology and tele-technology, for which we need to integrate the technology along with the resources. And to tell you that according to WHO, the mental health service relies on the competence of the people, that is professionals, personnel, to promote mental health, prevent disorders, and provide care for the people with the mental disorders. So with this, I would like to conclude and hope to listen to others. Thank you very much.
Can we have Dr. Prince coming into, please?
Yes, sir.
Okay, thank you.
Okay. My topic is about suicide among elderly, mental health concern due to this new COVID-19 situation. Why this topic is important? We have less media attention towards elderly suicide, attention in research and literature compared to other groups like adolescents and young adults. Lesser or weakening support system for the elderly, and again that is getting more weakened due to this COVID-19 lockdown situation. So these are the reasons why we need to consider elderly suicide as an important aspect to deal with from mental health perspective. I would like to talk about one particular case study. This happened a few days ago in a suburban of Chennai. A 65-year-old male and 63-year-old female, husband and wife, they committed suicide. So this particular thing drew my attention. I probed further, but I couldn't get a more scientific framed research. But definitely the consequences and the causes really demanded how social work and mental health profession can deal with elderly suicide effectively, the lessons that what we can learn from this particular case study. He was a carpenter, middle income group, skilled laborer, was getting his both ends met considerably well. They had very good family relationship. There is no marked marital disturbances. They had 3 sons. The third son was an alcoholic. He's living with the parents, but a very strained and discontent relationship. But even the other 2 sons, if you see their relationship, that was not a cordial relationship, but that was also a kind of disturbed relationship. But this was mainly due to this COVID-19 situation, not physical contact, not much of physical contact with the parents. So they ended up their life by hanging, the second most popular method of suicide in India. So this is the situation. They were starving, no food, and they wrote a suicide note and they ended their life. Okay, so it's a very primitive research. Let me say that it's a qualitative research. Case study method was used, a secondary source of information, newspaper analysis, telephone interview. We are not able to get more corroborative information from the family or other significant people, or even health records we were not able to access due to this travel limitation caused by COVID lockdown. This is another important thing we need to keep in mind in the research, how these things are affecting the research. So it's a theory-driven investigation, how this COVID-19 lockdown and anomie, that's a concept explained by Emile Durkheim, the French sociologist, how this theory-driven investigation hold promise in addressing the gaps. These gaps are necessitated by this COVID-19 situation, like lockdown or anomie. So that will help us systematically to identify the mechanisms and also to prevent such things and also for specific intervention. Okay, so Durkheim wanted to demonstrate that the suicide rate provided a measure of social pathology. He talks about 4 types of suicide: egoistic, altruistic, anomie, and fatalistic. Anomie is a condition which causes the people to feel lack of belonging and they are disconnected from the society. These are some of the proven factors through many research, like alcohol abuse, dependence, abstinence, marked physical illness, personality traits, other health issues like depression, bipolar depression, severe pain, congestive heart failure, chronic lung diseases, not diabetes, breast cancer, or prostate cancers. These factors were not there with the couples who committed suicide. But there was functional impairment, social isolation, and decreased social support due to this COVID-19 lockdown. So even Paula Clayton, a member of American Geriatric Association, he says single, divorced, and widowed are more prone to suicide. But in this particular case, they were married couple. So suicide reflects the character of the society. Talking about Durkheim's theory, anomie theory, so impairment of socio-psychological health, how that leads to suicide. When social conditions fail to provide people with the necessary social goals or rules at the appropriate levels of intensity, their socio-psychological health is impaired, and the most vulnerable among them commit suicide. This particular perspective of Durkheim explains the cause of suicide. In the case of G and S who committed suicide, if you see their social support background, not strained relationship between the spouse. They enjoyed the culturally expected social support, having three sons. Having three sons in Indian culture, male-dominated society, it is considered to be an advantage for the elderly people because the sons will take care of them in the old age. So this is an implied cultural expectation. But what happened because of lack of physical support, lack of transport due to this the COVID-19 situation, lockdown, they were not able to provide the social support because of the lack of physical support. Durkheim talks about the relationship between the society's suicide rate and the way it performs this regulative function. The important regulative functions of the society are provision of satisfaction and the meeting of the basic needs that was not done to this couple. Socialization that was affected, their interdependence with the sons, their relatives that was also affected, their goal attainment, their basic needs and the money, primary reinforces and secondary reinforces, they were also affected. The system of communication was affected, the system of protection and distribution of labor. This is because of the loss of job that was also affected. So here I am explaining how this regulatory function of the society is affected because of COVID-19 lockdown situation. He also talks about the relationship between birth rate and suicide. So the low birth rate led to the weakening of the family. But here in the case of G and S, they had better birth rate. They had 3 sons and grandchildren. So the social health situation was seemingly better for G and S. Though they had implied social support, increased the birth rate, they were not able to escape from that because of the COVID-19 lockdown situation. I'm re-emphasizing and reiterating that these COVID-19 lockdown are some of the new variables that we need to ponder, we need to take into consideration when we discuss and provide intervention for the elderly suicide. And we talk about the relationship between cultural and how it has led to the suicide, and especially how it affected the women, the wife who committed suicide. Durkheim defined that the women in traditional families, as they are socially integrated, they have better existence. Even though in this particular case, the women seems to have enjoyed the social integration, but better integration, but that didn't help her. Even the high rate of attempts of suicide by the women suggested that suicidal behavior was a common way for women to express their profound unhappiness. We couldn't establish whether that was there with the women, but what I'm trying to explain here is in case of male dominance by the husband, probably many studies we could find and we could analyze. Usually they kill the woman, then the male person will commit suicide. But here, women's submissiveness, a gender stereotype in Indian culture, being a submissive woman, she was not able to take decision for herself, or she was not able to take a decision, not able to say no to the decision by the husband. So whether it was a joint decision or an imposed decision on her, we need to do further research. So the strong husband and wife relationship was also affected by COVID-19 lockdown. Many studies nowadays prove that during this COVID-19 lockdown, the family bond is increasing. So even in this particular case, if it is increasing, that proved to be detrimental for this elderly suicide. So there are certain possible intervention that we can think of at the individual level. Telephonic voice message, when we call a person now the government of India, even the state governments, they are spreading the message about COVID-19. Probably whether we can include elderly care messages in that voice message. telecounseling and online counseling, which are effective in Western countries, whether that model can be applied in Indian culture, Indian system. Community level care like neighborhood support, neighbors visiting the people, frequent visit by the community worker or Asha, even postman visiting the elderly person, are they trained to deal with the problem identification and referral. In India, we are all aware that the fans club, religious groups and voluntary groups, they are very keen in helping the COVID-19 patients, infected persons, whether they can be trained to deal with the problems of elderly. Community-based organization providing medical and psychosocial support. And again, I'm reiterating the community-based service to these elderly people. To the government, the welfare measures like old age pension, how far that is effective and how they are meeting the needs with this pension. In a neighboring place, Pondicherry, they are providing 2,000 rupees, but in Tamil Nadu, we are providing only 1,000 rupees. Whether the 1,000 rupees will be enough for them, we need to do an independent study. Creating awareness about mental health needs of the elderly, even by way of popularizing the Elders Helpline 1800. And even in this particular case, the substance abuse intervention and support to the unemployed youth, the alcoholic son, who was also a major factor in this particular case study, they were not able to get proper treatment for this substance abuse intervention in this COVID-19 situation. Even other medical health issues like common fever or a major illness, when we go to hospital, hospitals are showing the door. It's another important concern how during the lockdown COVID-19 situation, we are not able to get proper medical help. So linking with the local panchayat and ward level councils, whether they can take census of elders in that area and they can take care of the elders. So such intervention will definitely prevent suicide. To conclude, there exists a relationship between ANAMI and COVID-19. So these are some of the new variables explain the cause of elderly suicide. This is not a hypothesis. This case study will help us to have a web of assumptions. Based on this, we can go for another or rather multifaceted evidence-based research. So ANAMI, due to this COVID-19, created a new social disintegration, which proved to be an important theory and variable for understanding suicide among elderly. The limitation of this study is that we couldn't use Schneidman's psychological autopsy. He talks about 14 criteria in assessing the suicide incident. We could use very limited information from this psychological autopsy. So there is a great scope for a detailed case study. We need to dwell upon these new variables created by the COVID-19 situation to deal with the elderly. Thank you.
Thank you very much, Dr. Prince. Very, very important, and I'm sure many questions will be there from the audience. I find that the chat group is not very active, unlike yesterday. Please do share your point. There is one question from Shiba. We'll take it up after the next presentation. Dr. Teo, can you come in?
Yeah, thank you very much. Okay, very good afternoon, ladies and gentlemen. Yeah,
take your time.
Yeah, no, I have 10 minutes. Yeah, I'm starting my timer now. Okay.
Thank you.
Okay. Good afternoon, everybody. Thank you, Dr. Srinivasa, the chair for this session, distinguished speakers, and I would like to thank Madras Christian College for organizing this important webinar talking about the issue of mental health. I'm Teo from Malaysia. I'm a lecturer in social work from University Utara, Malaysia. And today I'm going to talk about, I'm just to share my experience, yeah? Okay, let me just switch on my PowerPoint. Okay, so I would like to talk about the Commonwealth Charter, okay, and also the social values. As I put it here, I'm the current chair of the Commonwealth Organization for Social Work. Yeah, this is a voluntary organization. I think Dr. David Jones already explained about the background, yeah, and what the Commonwealth COSW is doing. So I hope more will be interested to participate, you know, to join the COSW and be active. Okay, my presentation will be in two parts. One is our focus on the Commonwealth Charter and what is a relationship to our values and principles, our social values and principles. So because there are some similarities that I think we need to understand, we need to take note, yeah, and then some the potential within the Commonwealth and COSW for the social profession, and then the second part I will talk about an overview of the mental health service in Malaysia as we talk about as the the webinar is on mental health, yeah. Okay, so I would like, okay, let me just skip this because I think Dr. Gottfried already talked about the Commonwealth in general yesterday, yeah. So it's a large population, but consists of big and small countries. Okay, I would like to bring your attention to what happened 9 years ago, almost 10 years ago, yeah. During CHOGM 2009, the leaders, okay, when they were meeting in Trinidad and Tobago, they agreed to establish an eminent persons group, okay, or EPG, to look into how to reform Commonwealth, yeah. So so the EPG was set up, and they have to present a report to the leaders during CHOGM 2011. Okay, why I mentioned the EPG? Okay, as you look at the slides, okay, the EPG was comprises of eminent person from different parts of the Commonwealth. Okay, the chairperson is from Malaysia, yeah, Tun Abdullah Ahmad Badawi. He was the 5th Prime Minister of Malaysia, which I have the privilege of serving. Yeah, I was serving him from 2004 to 2013. Yeah, so I was following the process of this EPG. I always joke that I took a sabbatical leave from social work for almost 10 years. Yeah, so okay. So the EPG, yeah, as you can see in the slides, okay, comprises of many eminent persons from all over, selected from the current countries, and they were supported, yeah, by the Secretary General then, His Excellency Mr. Kamalesh Sharma, who is from India, yeah. So they have intensive consultation, yeah, throughout the 1 year mandate given to them, okay. And they received over 300 submissions from the Commonwealth organizations. Yes, as you would have known yesterday that there were over 80 Commonwealth organizations, yeah, or civil societies in the Commonwealth. And the key questions where the EPG members were looking at was, what, you know, was the Commonwealth still relevant? Okay, and from there they published the report, which is called the Commonwealth of the People. Okay, because they feel that Commonwealth is actually, okay, is a value-based organization and it's about its people. So they propose many things, okay. There are two, and if you look at the proposals, yeah, apart from the charter, a lot of other issues are also, you know, maybe some of the social workers are also interested or working on migration, on young people, on women, on HIV/AIDS, yeah. Okay, and the Common Charter was proposed and it was agreed, and it was signed by the Queen, okay, in 2013 during the Commonwealth Day. And the Charter encapsulates the values and principles and also shared goals of the Commonwealth. And if you look at the core values and principles of the Commonwealth as stated in the Charter, it's actually congruent and consistent with our profession. You talk about human rights, you talk about social justice, you talk about self-determination, you talk about participation, respect, integrity, they're all there, okay? So that's my purpose. I want to, you know, why Commonwealth is relevant is because it's value-based, and social work is also a value-based profession. And I can see there's a lot of link between the profession and what Commonwealth represents. Okay, so this is where I hope that we will participate, you know, more and more social workers within Commonwealth can participate. And there are 3 organizations that support, yeah, the work of Commonwealth. For the professionals and for the civil society, normally we will work more closely with the Commonwealth Foundation, yeah. So we are active, and I hope that COSW can continue to play a active link between social workers within the Commonwealth to stay connected to among us and also with the Commonwealth Secretary and also Foundation. Okay, then this brings me very quickly Okay, I have only 4 minutes left on the mental health service in Malaysia. Yeah, mental health, we have in Malaysia, we have mental health during the British occupation, or the colonial days. We have the Mental Disorder Ordinance 1952, and it was only in 2001 that Malaysia government, okay, enacted a new act. It's called Mental Health Act 2001. Okay, the old ordinance, the Mental Disorder Ordinance 1952 actually put the responsibility of mental health service on to the government. So it's only government can provide mental health service. And so that's why the government amended the law in 2001. One of the aim is to encourage more private hospitals and private mental health providers to come into mental health service. Yeah. However, the Mental Health Act, 2001 didn't come into effect until the government completed the Mental Health Regulation 2010. So it took about 10 years. Yeah. I was when I started teaching social work back in 1999. Yeah, and one of my area of study is actually looking into community care for people with long-term mental illness. So I was at that time quite actively participate in seminars and workshops with quite a number of psychiatrists who are promoting community mental health. But it took a long time, because without the regulation, a lot of things wouldn't move. So when the mental health regulation came to action in 2010, so the government started to roll out community mental health centers, supported by the community mental health team. However, until today, there's only 22 community mental health centers. Why? Because there's a severe lack of mental health professionals. Just now, Dr. Syed Kumar mentioned about there are 3,800 psychiatrists in India. Well, Malaysia is not very well off as well. We have only about 381 psychiatrists in the country. So it makes like 0.5 psychiatrists per 100,000 population. Okay, and we have I think the situation in Malaysia is the same when it comes to clinical psychologists. We also have very short of clinical psychologists. We are at only about 100 over, clinical psychologists employed. So then why? But the mental health service in Malaysia doesn't include social workers. We have medical social workers. However, in a study by my colleague Yusmahaini Yusuf, published in a journal in 2019, she studied on the 279 medical social workers in Malaysia. As you can see, only a handful, 12 are assigned to do psychiatric or mental health work. The rest are all hospital social workers. They are not in mental health. And then our social education in Malaysia are mainly focusing on the undergraduates. Only 3 universities offers Master of Social Work, with one, which is my university, offered a concentration in health and mental health. Another one, specialization in medical social work. So what I wanted to say is that, the social profession can, we are not known, although we claim that we are, but we are not so much recognized in the mental health service, not in the government service anyway. So that is something that for Malaysia we have to work very hard, and we have to learn from India, how we are going to promote, to get more social workers into mental health. And mental health subject is not compulsory for all the social work students at the undergraduate levels. So to conclude, what I want to emphasize is that Commonwealth is a value-based organization, and so is social work profession. And the Commonwealth is not about economics. It's about people and the values and principles that we uphold. To advance the well-being and prosperity of other people that we serve. So to conclude, if you want to be relevant, yeah, if Commonwealth wants to be relevant, the eminent person says that, then you have to live up to what you preach. So as a social workers, okay, if you want to be relevant, then we also have to uphold the values and principles of our profession in practice. So with that, I thank you.
Thank you, Teo. Hold on, I'm going to ask you a question from the audience. You know, what do you think is the mutual way of learning across the countries of the Commonwealth, since we all share a somewhat similar cultural background? What are your thoughts about it?
Okay, how do we share?
Yeah, learn from each other and share with each other. And what is the mechanism that we can use it?
Okay, I think what I've listened to the presentation yesterday and today, I think we share a lot of similar situation, and especially mental health. Yeah, it's underdeveloped, under resources. Yeah, but I learned from India. Okay, I have to say what I can learn from India is that India already moved towards social work at the master's level. And at the master's levels, that is where the students are more mature and they can do specialization in mental health, as compared to if you are started at the bachelor degree, okay, when they are too young, they may not understand and they may not find, okay, they may not have enough exposure to go into mental health. And something that I noticed in the Commonwealth is that we don't have what you call psychiatric social work positions. I'm not too sure about it's not so much of, because it's unlike in the US, they have clinical social workers. Yeah. So for this is something which I think even in the UK, last time they have the approved social workers to do who are approved social workers in the mental health. Now they are called mental health social workers. So I think there are a lot of things that we need to maybe okay, we have still a lot of things to learn from each other and see how we can what we call advance in this area in the field of social especially in the field of mental health.
Thank you very much. I have a question for Dr. Prince from the audience. One is that there seems to be lack of uniform curricula for MPhil course, and also the training courses are not very good. What are your suggestions? In addition, I have a question from my side to you. You talked rightly about the socio-psychological health of the society. If you could elaborate a little bit.
Yes, sir. Regarding the first question, the Schools of Association of Social Work, we need to take it up, and we need to go for, if not 100% uniform syllabus, but addressing some of the newer issues like COVID-19 and elderly needs. Yeah, so these are some of the things we need to keep updating. There's no point in having uniform syllabus which are pertinent to the social and current issues of India. Okay, regarding the second question, see, suicide or mental health issues are multifaceted phenomena. So we need to look into the psychosocial and biological factors. See, but that's what I was trying to make my assertion more succinctly. Hitherto, earlier it was more of a psychological or financial reasons or the personality traits of the person who commits suicide. But here, how the social factors also vehemently coming into oppression of the people, how they are also, leading to the psychosocial factors affecting them vehemently. That's what I made it as an assertion in this case study.
Thank you very much. I'm going to ask one question to Sai. Sai, there is a question about what should we be doing in this human resource development about traditional healers. People tend to go there. Should we neglect them? Should we include them? Should we work with them? Should we fight them? What are your thoughts?
Mike.
Can you am I audible, sir?
Yeah.
Okay. So in the traditional view, that traditional healers, are not very welcomed by the professionals when they are entering into the profession. They start learning. But they do realize over a period of time that they cannot be neglected, because the psychiatric problems and symptoms, they occur in the context of socio-cultural system. Many patients, they integrate the socio-cultural elements into their psychopathology and they talk about it. So one of the immediate knee-jerk response of the community is that to go and seek help from the traditional healers, believing that it will help them. So in that context, we have to understand. Second, in the absence of necessary adequate amount of manpower to deal with the psychiatric problems in the country, they were the one who were providing care to a large number of people. However, it is a dispute that many of them were harming and all that. That's a different story. Third point is that we need to understand is that instead of alienating them from the system on whom the community has got a huge amount of confidence, it is better that we take them as a partner in our care of mental health care delivery system, on which, in fact, many steps have been taken, including from the institution like NIMHANS and many other institutions have taken a lead in training the traditional healers in basic counseling skills. So we should be happy that if they are able to be a partner in the system and treat the cases, mild cases, along with our partnership, I think that is a very good combination of mental health care delivery system in a developing country like India.
Thank you very much. I think we have only 5 more minutes to go, so I'm not going to. There are 2 other questions which probably will answer it in a little different way. How do you combine the older and younger people, and how do you promote community participation? But since time is limited, I'm going to conclude with a few comments on that. See, one of the biggest challenges that we have, as I pointed out in the earlier beginning, that everyone is recognizing that there is a global need for social contract all over the world. This is the words of Anthony Guterres, United Nations Secretary General, just about a week back. And the Institute of Medicine has brought out a series of books on community resilience, where we look at inequality, intolerance, adequate social supports, and other things. And in all of these things, the psychiatric social workers have a very, very important role to play. There are 3 things which I want to share with you as the possibilities for you. First and foremost, the most important thing is to look for our cultural strengths in caring for difficult situations. You'll say, how do we do that, sir? We always think of CBT, we think of psychoanalysis. That's why I put out to you in the chat box a recent book by Professor Malavika Kapoor, who was the professor of clinical psychology, and has written a very interesting book, Counseling for the People, by the People, of the People. It's a fantastic book. If it is in a Kindle, it's only 74 rupees. The printed copy is about 160 rupees, and full of anecdotes, actual case histories, and documentation how the cultural values have been used for providing mental health care throughout the life cycle approach. The second very important thing is for us to document what we are doing. Very often we tend to not document, as Dr. Prince and another pointed out, that documenting and looking at and taking forward the issues from one to the other is the most important thing. The third very important thing that we all have to do is empowering the people. Because if 40% of the people have anxiety, depression in the country due to the COVID, and 75% are saying that they have not feeling well and they feel stressed, no amount of professionals are going to take care of that. So we need to talk about self-care in terms of exercise, in terms of sleep, in terms of spirituality, in terms of yoga, meditation, in terms of eating right food, and also teach skills to get over acute stress. Let me just talk about 2 skills which no one talks about, which is proven to be very useful. One is called journaling. In all disaster literature, encouraging people to write down their thoughts and feelings is as good as going to a psychiatrist or a psychologist or a social worker. So if we can teach them, but the problem with most of the people is they don't know how to write, and they often write it up as a diary. But what we need to do is to teach them. For example, if you see Divya wrote a very nice article in the Hindu about journaling about 2 weeks back. I can share all these articles. I'll share my email at the end of it. You're welcome to write to me. I'll send you all these articles. And if we can teach people and make that a self-care activity, you would have achieved a lot. Similarly, music is a very important way of getting over tension, worry, fear. And in India, we have a rich tradition of music. Lastly, spirituality. For example, a study done in England just about 2 weeks back found that 80% of the people use spirituality as a way of coping with the current situation. In India, it must be 100%. But the question is, how do we translate the vague spiritual ideas into practical application? I can go on and on, but the point which I'm making is there are a large number of challenges in front of us. If we take it up, we would be able to add new knowledge, we would be strengthening what is available in the community, and also we would be meeting the big treatment gap that exists, the big gap between the distress and the help that is needed in the community. And I want to end by saying it's a pleasure for me to moderate the session. 3 speakers were eminent speakers. They spoke very well within the time constraints, and they have given us thought for thinking, food for thought rather. And I'm glad that we had this session. I myself, I'm very happy to be part of it because in Vellore, when I joined CMC Vellore as a medical student, we were 3 people in a class, in a room, and 2 of my classmates were MCC, Dr. N.M. Samuel and Dalit Mukherjee. Every day, day in and day out, I would hear about the stories about MCC, and I'm glad that I have been part of this particular session. Similarly, my brother, because we belong to old Tamil Nadu, before transfer to Karnataka, used to study in MCC in the 1950s before joining engineering. So lots of connection, lots of ideas, and wonderful to share this thing. And I think I'm just got about 60 seconds to say thank you to organizers, especially to Sylvia. Beautiful posters, beautiful presentation, and I am sure this will be the starting point for a lot of further interaction across all of us. I will leave my email in the chat box. You're welcome to write to me. Just about in the next issue of the Indian Journal of Social Psychiatry, we have written an article called Social Vaccines for COVID Pandemic. And it's an interesting one and worth reading it. And I'll send you the copy of the same. Again, lastly, thank you very much to all of you and good day. I hand it back to the organizers. It is exactly 4 o'clock. Bye.
Thank you, sir.
Thank you, sir.
Excellent.
Thank you so much, sir.
Thank you, sir. Thank you for your insights and for chairing the session. Moving on to session 2, which has 2 speakers, which will be chaired by Ms. Naomi Spencer. Presently, she is urgent lecturer with Charles Stewart University, a contract specialist counselor with the NSW Justice Department. She was a director of the National Australian Association of Social Workers board for 4 years. She has been and is on national and international committees and is on the board of the Commonwealth Organization of Social Work, COSW, and as an Asian Pacific representative. Ms. Naomi Spencer is the Vice President of Australian Association of Social Worker, Australia. Determined, a proven community activist who takes a pleasure in equity and justice. She has worked in community-based, non-government, local, state, and federal government position, as well as volunteer situations. Now, I take the privilege to invite Ms. Naomi Spencer to take over the session.
Thank you so much. It's a wonderful pleasure to be here. I will begin with an introduction and introduce my colleagues who will speak after I have introduced them both. And then we have some slides prepared for the question and answer session that may be of interest. And I'll conclude with some remarks. So thank you. I bring a welcome to you, my esteemed colleagues, audience, and contributors from the country the explorer Magellan called the Great Southland of the Holy Spirit, Australia. I am honoured to be here as chair in what I anticipate is the first of many more forums such as this. And thank you again and again to all who have been involved with organising this. I acknowledge the traditional custodians of the lands on which we meet, and I pay my respects to the elders. I extend that to Aboriginal and Torres Strait Islander peoples here with us today. Yesterday, Godfrey spoke of the impact and legacy of colonialism. I choose to see the opportunities and connections which it has provided us. A common language, common political, education, trade, and justice systems. And within that, social work practice and theory, which is why we are here for this splendid series of sessions. I have grown up, like many around the world, and indeed many of you here, with a strong sense of the contribution of the Commonwealth. For both of my multi-generation Australian-born parents, 7 generations here and the other 6, it seemed to me really strange that the United Kingdom, Britain, was home, but their world was Australia. My children find that very odd. Moving on, I like to think of this webinar as a welcome respite from the storm and hurricane that my colleagues yesterday spoke of from the Caribbean, but which COVID-19 has also brought to us around the world. Our own and others' mental health profoundly influences the way we respond and contribute, or don't. Has the eye of this hurricane disaster passed? How much longer will it be? Will countries be in lockdown? Will students have to pursue learning online? What does the future look like? How will we recover? The world will be irrevocably changed. Our countries need us, you, me, people of goodwill, justice, intelligent, resourceful, inclusive, skillful, faithful. The list could go on, couldn't it? Think of something that you benefit from and contribute in your social work context or personal. It is expected of us that, united across the nations, we will leave the world a better place. Let us remain undeterred by shifting political and strategic alliances, by economic and social upheavals. Thanks go to our young students and graduates. Actually, some of you are older students who are following where we have been and also treading new paths. Those like many of us on the panel, maybe some, those of us who are older eagerly and genuinely pass on the baton to our younger students, graduates and colleagues. Today, there are 2 presenters from Australia for the Asia Pacific section of the Commonwealth. Their work and contribution to social work practice over decades is a welcome beacon and example to many in our profession. It is a reminder of the power that each of us has to make a difference. And indeed, not the choice to, but the imperative to, because to whom much is given, much is expected. And it is in giving that we receive. May I introduce Ms. Pamela Trotman, who I've known since she was my social work supervisor almost 40 years ago. I know it's hard to imagine 40 years ago. I was young. Together, we've been social work activists and served on the National Australian Association of Social Workers Board together. Pamela is presenting on recognising and understanding traumatic woundedness. This paper draws on over 4 decades of work as a trauma counsellor and the presenter's own journey as a survivor to name and describe 7 different forms of traumatic woundedness. Vignettes are used as examples to describe how several different forms of traumatic wounding can impede post-trauma recovery. It then positions traumatic wounding as an important component within the broader knowledge base pertaining to trauma recovery and the reclamation of a fractured sense of self and relationships. Ms. Trotman has received many awards, in particular, Social Worker of the Year for the Northern Territory in 2010. And in 2019, she was awarded AASW Life membership. She is well published, and I'm confident that she'll let you know how you can follow up on those details. And I look forward to her presentation now, and we have prepared questions which will go into the Q&A section. And Pamela, I'll remind you after 6 minutes, but let me continue and introduce Armando. Let me introduce Mr. Armando Revilio, who I've known for almost 25 years, as well as being a staunch supporter of initiatives for community well-being. Armando has worked tirelessly to ensure that all in his sphere of influence have the experience of being valued and belonging. He's very well regarded for his perseverance and professionalism. On another level, Mr. Revilio, Armando, has been a great support in the local collegial support group, SWITS, Social Workers in the Shoalhaven, where I am the current convener. It is the largest practice group of its kind in Australia. We meet regularly and discuss pros and cons, what's happening in our community, and we've taken action together which have achieved important results for New South Wales social work practice. Armando has worked very hard in a number of contexts. He has worked in Victoria, a southern state, which is where he originates, and presently in rural regional New South Wales. His areas of work include community partnerships and safety coordinator, where he coordinates the functions of community safety, graffiti prevention, Aboriginal community development, social enterprises, which are a very exciting opportunity, social procurement, and place-based approaches across the local government area. He's been a manager of community planning, where he's contributed to the development and implementation of community development strategic directions by managing social planning, community research, community support, and the Burundara Volunteer Resource Centre. His other roles have included coordinating funding, managing social plans, and the equity team, coordinating support services. He has a very rich and deep work history contributing to community mental health and well-being. So we look forward to hearing from both Pamela and Armando. And if you would, that's all, isn't it? If you'd like to begin, Pamela, and I'll let you know after 6 minutes, and there's 20 minutes for each of my colleagues. Thank you. Hello, Pamela. Are you there?
Ma'am, you need to mute. Unmute your mic. Unmute your mic.
Pamela.
You're not able to hear.
Can we hear you, Pamela? Are you unmuted? Can we do it for her? No.
Hello, can you hear me now?
Yes.
I'll mute now.
Yeah.
Can you hear me now?
Yes.
So the microphone, webcam, change the speaker's still the headphone. Hello, can you hear me now?
Yes, we can hear you. Please go ahead.
Okay, good, thank you. I was hoping to use the headphones because I was concerned that the webcam would not pick it up sufficiently, but clearly that's not the case, and I apologize. So I'd like to begin by saying thank you very much for inviting me, and I congratulate everybody from across the globe who's been here and getting this webinar together, and particularly to the people at the college, to all those people. And I'm honoured to be here. I also want to say greetings from Darwin, Australia, and I want to acknowledge that I'm on the I'm actually on traditional land, the Larrakia land, which is the name given to the Aboriginal people who were the first custodians of this land and the First Nations people for this part of Australia. So I actually have sent in a PowerPoint. Is there any way that the technicians can get my PowerPoint up, please? Because I need my PowerPoint. Is that possible?
Yes, ma'am. 1 minute.
Thank you, because I've done a small PowerPoint and I'll be doing full of paper, but I've done the PowerPoint because I thought not everybody might be able to understand my Australian accent. So as soon as you get the PowerPoint up, I can begin. But while that's happening, I can tell you the story of how I've come here. I'm a survivor of a variety of traumas, including child sexual abuse and a whole lot of other, and numerous ones. In fact, I'm 73 in a couple of weeks. And the first 40 odd years of my life, I had major traumas throughout all of those. I've also been a trauma counsellor since I got into the role of being a trauma counsellor in the 1980s, when I started to assist mainly women who were having issues in their everyday life, but I had enough courage to actually ask them, is there anything else that's happened in your life that would actually have caused you to have great distress and things? And so I actually started, even about the same time as post-traumatic stress disorder was formally named, I started working in the rural areas of New South Wales, which was where I was working with Naomi, trying to support people who were trauma survivors. Thankfully, I was sufficiently progressed in my own trauma recovery journey to have actually been ahead of them enough to be able to be of some assistance. And I was committed to helping them find their way, because I knew it was their way too. They had to find their way just as I had to find my way. This is all culminated in a book that I've written, just published, which I've called Journeys, Triumphing Over Trauma, Journeys Beyond Woundedness. And it's that I want to talk to you about today, particularly the concept of traumatic injury or traumatic woundedness. The concept is, so, are you right there, Naomi?
And I'll 6 minutes, but you've had 4.
Okay, just tell me when it's 6, thank you.
Okay, yeah.
Thank you. So, so the concept, and I've written these down so for you to do that. So if anybody's looking at it, I'm going to write this out fully as a paper for people to read. So if I don't get time to talk about all of them, then please don't worry, fret. So I've called the notion of traumatic, the concept of traumatic wounding, or it means that at the time of the traumatic events or experience, there's some kind of psychological or spiritual injury. And it relates, not to the neurological aspect, but it relates to the meaning of those events or the experiences that attributed to that by the survivor. Most often I've observed that it manifests itself in the weeks, months, or even years, like post-traumatic stress disorder, after the events, when the person attempts to make sense of the experience. So, and often it occurs in tandem with post-traumatic stress disorder reactions. However, traumatic wounding is different to post-traumatic stress disorder. It's different because it actually is not embedded in the fight, flight, or freeze response. It's embedded in what, as I said earlier, the meaning that the person, the survivor, attributes to the experience. And it's that meaning is of course shaped by the person of who we are as people, often our gender, our belief systems, our race, all the things that make us up to give us some sort of social and cultural identity. It can occur in tandem with post-traumatic stress reactions. However, it can also, but it can also exacerbate them. It can trigger them. And I had an example of one young woman that I was working with, the very first person, one of the first people I was working with in 40 years ago, who had in my naivety and things, she actually had what I thought at the time was a catatonic reaction. I thought she'd just gone into some sort of catatonic state from which she would never return. But I had resolved, because of my own trauma, that I wasn't going to panic, and that I would stay calm, and that I would focus on helping her to stay safe. She was a young woman in her early 30s, mother of 4, who had, along with her sister, been violently sexually abused by the father from the ages of 5 and 6 to 15 and 16. And what happened was, in our discussion, is that she actually curled up into a fetal position in the chair and was completely mute. The muteness was interesting because when at 16 they'd lived on a property in the country, and the father was abusing the younger sister, so she had run to the next door neighbour's property and had asked, and it's demanding for a gun because she was going to kill her father because of what he was doing. And having spoken the unspeakable, she then was mute for 3 weeks. She told me that she was mute for 3 weeks. She hadn't had any history of post-traumatic stress disorder there, but I think it was because her children, particularly her daughters, were getting to a similar age that she actually started to seek counselling. Anyway, what happened was there, and so that was the context of that, was that she was in a state, and so that's where it differs. It's the cultural and the social and emotional and even political context which makes for the difference, because with PTSD, as we all know, it's the triggering of the neurological response of fight and freeze, which can't be, which when people have difficulty regaining their balance from, and it can get re-triggered. So and this, one of the things that's happening in Australia in the last few years ago, we had a major Royal Commission into sexual abuse, institutional child sexual abuse. And one of the things that happened there, the most, of all the stories that are told, and I have to confess I didn't read them all, and I didn't listen to them all, but the news reports that of the children who, of the adults, now adults, who were giving evidence, their response was that the biggest thing that caused them the struggle post the experience of being sexually abused, particularly by priests. You may recall that we had one of our highest members who had actually, priests who had actually gone to the Vatican. He was charged, jailed, and then acquitted for having sexually abused children. The stories of these children, adult people, and their woundedness that they spoke about, was they were talking about the aftermath, and the aftermath was not just the abuse, but they were denied. They were actually denied, and that they were never heard. Their voice was never heard. And if we listen to trauma survivors, frequently they will say it's that we have not been heard. And that takes me to my next screen. I think, am I going all right with time, Naomi?
You've got 10, you're halfway through. There's another 10 minutes.
Okay, so put me through. So I'm going to do this. So, okay.
I'll tell you in 6 minutes, and then you'll have 4 minutes left.
Okay, can you put me onto the next screen, please? Okay, so in my time, both in my own experience of trauma and in listening to countless stories of survivors, I've identified 7 different forms of what I call traumatic injury. And one of those are injustice. The injustice is where the person, remember in the context, that if something has happened where there has not been, where there has been a feeling of injustice or not right, then that is what that's what they will say has caused the injury. The next one is one of denial, and that's that not being heard, because when we're denied and when we're not heard, then we actually have our humanity denied. We are denied as people. And I can remember even as a small child that as this man was attempting to penetrate me, I can remember thinking that he was denying me my childhood. Now that's pretty blunt thinking, but that's the reality. He was not treating me as a child. He was not treating me as a human. He was using me purely for his own gain. Similarly with rejection. Rejection is where for some attribute that the person may have, some inalienable attribute, the person is cast out, cast aside. And one of those is that or taken away. And that the story of the stolen generations in Australia is one such story that because of their Aboriginality, excuse me, because of their Aboriginality, where this is the stolen generations of those children of 3 generations, so 75 years of Australia's first 75 years of history as a nation was marked by the removal of Aboriginal children born of Aboriginal mothers and white fathers and placed in institutions of foster homes and adoption, because as a partially black child, they were not good enough. So they had to be placed elsewhere. So that's a testament to that sense of rejection of their Aboriginality. And with that, the stolen generations, even though the policy stopped in the early 70s, the sense of grief and loss still is carried by the generations that follow. Then there's one of moral injury, which has become quite highly regulated, highly recognised, particularly in military circles of notion of moral injury, where people have been forced to do or have witnessed things which have gone against their own moral code. Shame and guilt are separate, where the people are made to feel shame. So Aboriginal people were made to feel, the removed children were made to feel shamed for their Aboriginality, for their blackness and their culture. And there's lots of research now that talks about the extent to which racism and the cause of ill health, general health indicators, including mental health indicators, for people of colour is the basis of racism. And the last one, though these are not any order, the one is betrayal, is where this happens where there's intimate relationships, in particularly domestic violence and child sexual abuse, where there has been a betrayal of that absolute sacred bond that says that the child should be protected, or the spouse, where somebody has vowed to honour and look after, and then proceeds to abuse most violently. So that's them. Thank you. If I can have the next screen. Okay. So one of the things I've discovered for myself, and because I've had counselling too, but one of the things that I've recognised and is that with the awareness of the understanding of mirror neurons and the importance of the empathic connection or the tuning into the client, that's what's helped me to actually finally come to understand the concept of the traumatic injury or the woundedness. And it's access to respectful inquiry, that sense of not trying to get, not the counsellor, not trying to get an assessment or an analysis or a diagnosis, but simply speaking to understand what it means, what the trauma has meant for the client and its aftermath. And it's access to the counsellor's felt experience. It's not something that you sit there and cognitively feel. And it comes with the counsellor's engagement with the right brain, which is the empathic tuning and active recognition of the mirror neurons, as I said. And one of the powerful ways to promote that connection is where I've taken the time in being able to put in my own words what in a tentative way, what I understand might be to be what the emotion and the content of the client's trauma narrative, something which I've sensed as part of that empathic attunement. So it's not a cognitive assessment. It requires us as counsellors to put aside any preconceived ideas and assumptions about trauma, its contents in what it means. So do I have a little time? How much?
3 more minutes.
Thank you. So I would like now to read a brief passage from my book to highlight an example of empathic attunement. It's on the chapter on moral injury, and I'm out talking at a home visit to a man in his 50s who has recently attempted to commit suicide. He was a drug user, and he had been hospitalised as a result of the suicide attempt and had spent time in ICU. And I'm going to have to take my glasses off because despite the fact that I'm 73, I actually need to take my glasses off to read close first. So I'm reading from when I'm in the door. Searching eyes took in my every movement, and as I spoke, I could tell he was hearing not only the words I uttered, but their emotional intent. I can recall thinking, this man is a survivor of the first order. I knew I had just one chance to make a connection. I paused. He took time to roll a cigarette, only shifting his gaze momentarily, the rolling movement possible from habit. He lit the cigarette and drew on it. This allowed me time to gather my thoughts and think about where to next. I had succeeded in getting through the door, but nowhere near him as a potential client. I found myself saying, you and I both know that nothing I can do or say will prevent you from trying to kill yourself if that is what you really intend. I'm here firstly because you have indicated that you want some help. I'm staying because I suspect there is something gnawing at you which you cannot escape. He stared at me for a long time, drawing on the cigarette a few times before responding. Haltingly at first, he told of how he experienced terrifying visions of being at the gates of hell when he was in the induced coma, following the recent suicide attempt. I can still recall myself thinking, my God, this man is in a dreadful position. His life has become unbearable, yet he is terrified of dying because he now believes hell is waiting for him. I decided to share this insight. As I spoke, his eyes filled with tears and he began to recount his younger days when he engaged in violent street crimes, never caring if he had seriously harmed anyone or stopped to check, though believing in some instances that he had. Unbeknownst to me, I had knocked on the very door he had kept locked for decades. Having knocked and him opening it, I realised I was encountering a man who carried a great deal of shame and guilt and remorse for his actions, even though he could rationalise why he behaved that way. I didn't need to be judgmental. His inner judge had been condemning him for years. I think I said something to that effect. So to reiterate, it's not a cognitive assessment. I don't think I would have got anywhere near that man. He actually engaged with me and we started talking about, and he realised, and he ended up by saying that he thought he'd probably still end up in hell, but by the time he had left, it was that he was going to use the time to atone for and make as many amends as he possibly could for the people he knew he had hurt, and so that he could go confront hell, knowing he had done everything on this earth to amend and to atone for his sins. And I could
be winding up and finishing.
Thank you.
Thank you.
And thank you, everybody.
Thank you. Thank you very much, Pamela. I'm sorry to interrupt you. If we can go on to Armando. Mr. Revilio, please.
Yep. Hello.
Hello, welcome. Over to you. Would
Thank
you
you,
like
Naomi.
a 10-minute nudge?
Yep. Yes, please. Thank you. Thank you, everyone. Thank you for the opportunity to present to you today. It's certainly an esteemed panel of colleagues around the world, and I hope I can contribute something to today's discussion. As Naomi said, I'm just going to bring up on the screen my PowerPoint, if it'll let me. Yep, here we go. There we go. So I'm just going to, just a second. Yep. Okay. So I'm going to talk about a project I've been involved with for about 5 years, the Bellambi Collective Impact Project from 2015 to 2020. It's a community-based inclusion project for developing community capacity and well-being, which ultimately aids mental well-being as well. I also want to acknowledgement of country. I want to pay my respects to traditional custodians of the land on where I'm sitting and have worked for the last 24 years. I pay my respects to Aboriginal elders past, present and emerging, and their wisdom and knowledge they provide to us in both Aboriginal and non-Aboriginal communities. And I extend my respect to any Aboriginal and Torres Strait Islander people attending this webinar and all of those who are my colleagues that were involved in this project. There are many paid and unpaid people that are valuable in our community. So, Bellambi, I'm in New South Wales, where Naomi is, and so Sydney's about 100 odd kilometres away, and Wollongong is a local government area of about 210,000 people. And Bellambi is a suburb of that Wollongong local government area. Some of the key facts. Bellambi has about a population of 4,000 people. The collective impact area covered about a quarter of that, about 1,000 people. And of that area, 75% of those people lived in social housing. There are high levels of social disadvantage. What is collective impact? Well, it has lots of names, but a definition that I've got here too are that a collective impact is a model which aims to protect the most vulnerable in our society and break the cycle of disadvantage through cross-sector and community collaboration. It reduces government's prescriptive role, clearing the path for local community to lead the way, supported by the business sector, not-for-profit sector, and all levels of government. It also could be seen as a social action research model approach, in that the work we do will change and will be impacted by new information that comes along. The other thing about this approach, it's a collaborative approach of many partners. One of the leads was an organisation, a not-for-profit organisation called the Australian Social Investment Trust. Sorry, typo there, missed that. ASSET, as it's known, its aim is, and to quote from their website, to support and facilitate investment initiatives which create long-term social and economic benefit to Australian communities. They understand that there are many complex needs for our society, and at ASSET we find the solutions to meet those needs head on. That's its purpose, what it aims to do, Australian Social Investment Trust. ASSET was engaged by the New South Wales State Government, at that time the agency called FACS, Family and Community Services, which is now called Department of Communities and Justice. And that government department engaged ASSET for a 5-year period to facilitate the Bellambi Collective Impact Project. Some of the other collaborative partners are in my council and Wollongong City Council, and we have a staff of over about 1,200 staff at Wollongong Council. I coordinate a community safety team, which has crime prevention, graffiti prevention, Aboriginal community development, as was mentioned earlier, and a few other factors as well. But also we have a community development, general community development team, youth services, facility support team, and maintenance crews, those gardening crews and road maintenance crews. You may ask, what does that have to do with mental wellbeing? I'll lead into that a bit later. The other partners were New South Wales State Government, and that was a key thing, that it was a directive from the Premier's office that police, health, education, child protection, community programs, and other government agencies were to become involved in this project and try to not to be bureaucratic in their approach. Another way of looking at this is asset-based community development, or ABCD approach. So one of the things we looked at is, what are the assets in Bellambi? And there are lots of them there. The residents themselves, there were some great community champions and future leaders with support became future leaders in their community. The Bellambi Neighbourhood Centre, or community centres as it may be called, was a key asset where lots of people meet in their various programs. Food, nutritional programs, meeting programs, youth group, child related development programs were happening there. A unique one probably for Australia, and you'll see by later on when I give you a picture, is Bellambi as a suburb is right on the beach. So the Bellambi Surf Club was a key community asset, and the club chairperson was very much wanting to be involved in the project, and that became a key asset, and I'll talk about that a bit later. Not an obvious one that people think of. The other one's a Bellambi Primary School and Corrimal High School, and an organisation called Wollongong Northern Aboriginal District Community, WINDAC. Probably Bellambi has, it's one of the higher populations of the Aboriginal community in our local government area in Bellambi. Local businesses and other not-for-profit organisations. These are all community assets that are rich, and we need to work together with them in our approach. What occurred in 2014 was some major community safety issues where police, child protection, health, mental health, education, and local government were all coming together over major crime and dumping of rubbish and a whole lot of things happening in this community. And I must say, sort of through one of my agitations, as Naomi would say, or community advocacy role that social workers do, I lobbied my state government colleagues saying, we need to do something now. This is major. And out of that, and fortunately at the time, the regional manager of FACS, or Family and Community Services, the state government came on the idea of collective impact as a way of working. Or you could also say community development as an older social worker of nearly 30 plus years, 35 years now, it is a form of community development. What happened was a Bellambi Community Action Plan was developed by the community. There was co-design sessions early in 2015 with over 100 people involved, and the majority of those being residents in the area who often didn't engage with many services. And out of that was born was the Bellambi Community Action Plan from 2015 it started, but late 2015, but 2016 and 2018 was developed and focused on 4 key areas that the community identified. The community said they wanted community safety and the physical environment improved. They wanted connections, support and inclusive community. They wanted community-focused services. They wanted learning, education, and employment opportunities. In that plan, 110 plus unique actions were developed to be completed over 5 years. Some of those actions are still ongoing, were always meant to be ongoing, and I'll speak about those a little bit in a moment. So this was my main domain in the safety and physical environment. The 3 community aspirations that make up this theme, that the community said, we want a clean and beautiful environment, free from rubbish dumping and graffiti. Public places, we want play areas and streetscapes that are welcoming and cared for. A community that feels and is safe, including roads and beach safety improvements. And often these aspects, I've sort of become the wisdom as in my career that these are equally as important as anything intrapsychically to people's mental well-being. If you live in an area that feels unsafe, that looks unsafe, that is full of rubbish, and you feel unwanted by society, you will react that way, I believe. And often people feel disconnected to their local community and to any services. So that ability to feel connected is very strong. Some of these physical factors impinge on that, and that's why this became very important. Some of the key actions and outcomes that have been achieved over the last 4 or 5 years include graffiti was removed on a more regular basis, and we did a number of graffiti prevention murals. And by that, I mean, we employed artists, community workers working with different groups, children under 10, adolescents, also Aboriginal community, older people, and a variety of people were involved, and themes were developed, and those murals were drawn or painted and attached to significant parts in the Bellambi area, the community centre near the surf club, etc. And that not only prevented graffiti, but it also meant the amenity, the feeling of the area improved. People felt really good. One of the things that are just simple things sometimes in our social work practice is, how do people report graffiti and who to? Lots of people over the time become so disconnected and didn't want to engage with the housing service providers. They didn't know who to report graffiti to. So we spent a lot of time just saying, here's one number, report it to here. It doesn't matter who owns the graffiti, what asset it's on. We will take care of it. We will get it, whether it's housing, whether it's the road services, whether it's council, whether it's the electricity supply. We will you can contact that one number. You can email it. You can ring us up. You can tell us about it, and we will contact the correct agency to remove graffiti. So I'll keep moving. So the other thing was establishing a community safety group. So the residents and one of my team members formed a community safety group, and they met monthly and looked at what are the safety issues in the area and started to deal with those. The other thing was police connecting with the community through events and regular meetings. They became more visible, so people trusted them better. And the result of that was more crime was reported to police, which was a positive. We completed 10 community safety audits, which uses the principles of CEPTED, crime prevention through environmental design. So we look at design features that reduce crime, the opportunity for crime, and increase people's perception of safety. And as a result, people said they feel safer in the area, and actual crime did reduce. A couple of other things. We had regular cleanup days. We developed a way of removal rubbish. That was just simply a bureaucratic error where people couldn't say what house they lived in, and we resolved that by just changing the plan with our waste collectors, so people could say, I can have my rubbish picked up. Reporting of illegal rubbish increased. Needles and syringes were cleaned up by health services. Play areas were cleaned and maintained. Simple things like a barbecue, seating and shade amenities were provided with a beach grill. There were free children's learn to swim programs, and approximately, I think, 150 to 180 children participated in that, which means their families participate, which means more connectedness, and they feel part of the area. And finally, the police and TAFE, which is an education institution, ran a mentoring program for community leaders in domestic violence prevention, which is a key area. So I'll quickly go through some of the others. Connections, support and inclusive communities. The 3 community aspirations that made up this theme are a positive image and perceived reputation in the area. People connect through regular activities and build the skills and relationships with community members, and more low cost and free activities for children and young people. Often in highly disadvantaged areas, people can't afford many things. So low cost and free activities are very important to feel included, to feel connected and supported. There was more community activities and events which were free or low cost, which increased community participation, and larger numbers of people came to these activities. They came out of their houses and came to the activities. People became more confident about voicing their opinions to all levels of government, where before they wouldn't say anything at consultations or engagement, they actually voiced them in an appropriate and constructive manner. And the government agencies responded in a more appropriate, constructive manner. People were saying they feel heard and had the opportunities for community leadership. As someone quoted, "I would have never done this a few years ago, but look at me now." And they've since become one of those community leaders. The other actions, residents were encouraged to attend the Bellambi community lunch each week to get to know their neighbours. Local residents were supported and eventually became volunteers at the neighbourhood centre. There was a transition to schools program involving all the schools. So children that are about to leave preschool and enter school for the first time, they actually had a transition program. As I said, we've developed more low-cost free activities for children. And the other one was mentioned, Aboriginal Reconciliation Walk, which from 2015 doubled in 2016 and has continued to improve to where there's over 2,000 people walking for reconciliation, which is acknowledgement of past hurts, and that together, side by side, we can work together and create a more inclusive Aboriginal community within our community. Community-focused services. Often what people were saying is, a lot of the services, government services, are focused on how their box is, and I have to fit into that box, is essentially what it's saying. So it's very bureaucratic. So it's saying we want the services to have in their heart to meet our needs and focus on us as people rather than meeting a criteria and looking at ways for that to make that happen. So there's improving the governance at the Bellambi Neighbourhood Centre to ensure that it can run and be sustainable for the future. There was a family partnerships program where families identified their goals, and the government agencies and services program came to meet their goals rather than, here's the program we run, this is what we can do. And there were also regular walk and talk opportunities for people to meet community organisations and find out what they provide. A walking bus tour, so people walked to different services and actually met them and found them in non-threatening ways. Some of the other actions were government and community organisations developed more culturally appropriate programs with our Aboriginal community. And that's a really key one. So there's more cultural sensitivity about how to engage with the Aboriginal community and elders in that community so that families felt welcomed and that they would be attended to. Service providers hold a shared values code now and hold one combined meeting per year so they can look at how collaboratively they can work together. There was increased promotion of services available at community events and school open days. So more of the services came to those open days and community events, had a stall and said, here we are, this is what we provide, come and have a chat. Less threatening than come through the door, sign the forms, we'll do an intake sheet, and then we'll tell you what we can do. The next one was learning, education, employment. The key aspirations in this area was increased access to learning and education and employment across the community. Families, children and young people are connected to education and skills development opportunities. Improved reputation of Corrimal community of schools as a local school of choice so that people want to go to that school, and engage, support young people who have dropped out of formal education to gain education and employment. Actions and outcomes increasingly noted that young people felt more engaged in education, more visible as a positive aspect of the community. There was a regular affordable barista training, as in affordable that people didn't have to pay nil cost to get the training to become a barista, which was a very employable skill in our area. If you like good coffee, there's good coffee at the Bellambi Neighbourhood Centre and around. People commented on private, there was a new cafe open in the Bellambi Surf Club. It was a social enterprise cafe. And as I said, that surf club became critical because it wanted to allow a cafe in there, which is wasn't there previously, then the cafe provides job opportunity. And also students commenting on their excitement around STEM, which is science, technology, engineering and management activities at their schools. Previously, a lot of kids have dropped out of that programs, children have dropped out, and now families and children were attending Coromel communities of schools because they're excited at the possibilities of what they can learn. Another outcome was there, just a good combination of social entrepreneurship was the encouragement of Bunnings store, which is a large hardware chain in Australia. I'm not sure in England or other countries what they are, but Bunnings decided to open a store and they were encouraged to open in Bellambi, and that created over 150 jobs, which are employment pathways for people, or work experience. They can get work experience there as well. As I mentioned earlier, the Social Enterprise Cafe at the Surf Club offers employment and skills learning opportunities, so it turns that around. A key stat was local children's access to preschool services places. Previously, prior to this project, there was no Aboriginal or locals young children accessing that preschool. With the introduction of this project, over 25 new families were now enrolled in the second year of the project. Childhood vulnerability decreased by 7.6% over the 3 years from 2015 to 2018. And a simple thing, an early childhood nurse was established in the Bellambi at the Neighbourhood Centre. So that increased early intervention strategies with young children under 3 in particular, engaging in early intervention programs like hearing, speech and other activities as well, whereas previously they would have reached primary school without having any attention. So some major health benefits there. And this picture, I know it's a bit hard to see, but this picture tells a story for me, or a new narrative for Bellambi from 2018 onwards. One of the things at the community meetings, we had a fantastic artist who drew up a lot of the pictures from the discussions of community engagement days. And this highlights to me, I think, the success. I can give you some other data of things that happened as well, crime data that reduced. But I think as a diagram, as a picture, you can see the strengths. I believe you can see the strengths in the community. This picture was drawn in 2014. You would have seen cars burnt out, rubbish, crime, and people not smiling, and certainly there. But the things like the little sign at the bottom, "We love Bellambi," the surf club area, is a big organisation. The neighbourhood centre is an important facility. There's a community garden. There's connectedness, and those 4 key goals are quite upfront as what that community wants. People have certainly become engaged, and it's a much more healthy community, well-being. People like living there now and enjoy the opportunities. And that's my presentation. I'll just unshare. If I can work out how to unshare.
Beautiful timing. Thank you very much. Thank you, Armando.
Yeah, I'm trying to get back to me now.
Okay. Should we go on to the question and answer session?
Sure.
I'm wondering if the technical assistants would be so kind as to put up the 4 PowerPoint slides, which have the reflections that we're inviting participants and the audience to read and reflect on. Perhaps while that's...
Whilst that's happening, Naomi.
Yes.
I'm wondering, in the chat room here, we've got several questions. I'm wondering, how do we deal with those, or if we deal with those?
I was wondering too. We have 5 minutes. I'd like to read my concluding remarks while the questions are coming up. And there's probably a way that we can respond with the chat, unless you'd like to look at them while I'm looking at the concluding remarks.
Pamela, there is a question to you. What according to, yeah, Pamela, this is a question to you. What according to you would be the best way to get out of the unresolved childhood trauma, which now is an obstacle in their own life, considering it has been caused by the parents and their lack of incompatibility?
didn't understand that. I'd actually like to read this and then we can consider it if it's written down. I wanted to thank everyone for their contribution and questions, and I would really love that we are able to answer them. And thank you for accommodating our Australian accents.
So Naomi, do you want me to answer that question or not? I'm sorry.
No, I'd like to do the remarks. We have a responsibility to finish it in 5 minutes.
Okay.
And then I'd love you too, Han. Thank you. Okay. I wanted to acknowledge the details that people have provided, which like a jigsaw contribute to a bigger picture of mental health, the experience of, the prevention of, and the treatment of. This conference and collaboration crossing international borders is an important part of and contribution to best practice mental health management, care, and amelioration. Our presentations about treatment and prevention. COVID-19 threatens to divert public money from prevention and treatment programs such as these. Groups such as social workers in the Shoalhaven, the ASW, various lobbying and advocacy groups are very important. And I want to urge everyone to continue to exercise their voice. And thank you, Pamela, if you'd like to answer the questions.
All right, before that, can the technicians get up my fourth PowerPoint slide that has my email contact address on it, so that if anybody wants to continue the discussion, I would be more than happy to engage in either a shared or an individual discussion. So that if I understand the question correctly, you are asking, can you repeat it please, so I can, because I'm not sure if I understand it correctly.
What, according to you, would be the best way to get out of the unresolved childhood trauma?
Oh, I think the issue is that the notion that has given me as a trauma survivor and working with so many trauma survivors, many, particularly those who are childhood survivors, is that we have within our brain, just as the brain is programmed to survive by the fight, flight or freeze response, there's now neurological evidence to demonstrate that the brain is also programmed for healing. And I guess that makes sense, because if we're constant as a species, if we were constantly made dysfunctional because of trauma throughout the millennia, we would not have been able to develop into such strong, capable entities. So for me, the focus is that we need to be on recognizing the impact of the trauma, but also finding ways to trigger that each person's brain to do the work, to start the healing journey, which is why I call it a journey, because it's not a one treatment fits all. Each individual, there's a question in one of the questions is about self-help, that each person, each survivor has to want to actually move beyond the trauma. They need to be actually to decide that they don't want to live like this anymore. They need to have the courage to engage in a process that helps them. And we have to take responsibility for ourselves, but we cannot do it alone. We need to have support. Now, whether those, and frequently the support is good from a professional, because with a professional, the trauma survivor doesn't have to worry about what's happening for the professional. So we can actually gain strength, and the more the professional gives recognition and credence to us and to our stories and to give credence to who we are and validates our trauma experience, the more we are able to move beyond it. And I think there's a question here about what policies and things are happening in Australia. Because of the major Royal Commissions, there's now a vast amount of money and community interest, community investment into providing support, counselling support and even financial support for the survivors of the traumas, for the stolen generations, for the survivors of the institutional child sexual abuse, and the creation of skills and the development of skills and knowledge that promotes and sustains that. And for example, and within the military, there's a huge commitment within the military, because tragically Australia loses more soldiers or servicemen when they come home from suicide than they do on the battlefield. And that's a major issue within Australia. I hope that answers your question.
We have many questions, thank you. And I'm not sure presenters, given it is finishing time, if we proceed with answering questions. We've also not put up our reflections. Technical team, are they available? There were 3 pages of questions. One, the reflections for the first speaker. Thank you. Could we just have a quick look at them? Can you go to the second page, please? Is it possible to go to the second page, or can I do that? No. Can you go to the second page? Anyway, let me tell you, the second and the third page were reflection questions. Really basically, okay, thank you. We have questions for you, the audience, around meaning, experience, relevance of the material and application. How do you see the link between this material and individual community mental health? These questions might give you, the participants, the opportunity to think about what you have just heard and to begin processing the information compared with your own experiences. And then some questions for those who are counsellors or for those who are trauma survivors. If we could go on to the next slide, please, slide 3. I'm sorry that there's not time to process this, but if you can be thinking of something that stirs you and that you might follow up. While we're waiting for the slide 3, I'd like to tell you about slide 4, which is an invitation for people to attend a webinar being hosted by the Commonwealth Foundation on eradicating modern slavery, an assessment on the Commonwealth Government progress on achieving SDG UN target 8.7. So it's a commitment for those of us who are very interested in human trafficking, and given that that's an issue around all the Commonwealth, you're quarterly invited to a webinar on the 30th of July, 11 o'clock London time. That's the 4th slide. So perhaps I had better wrap up and thank everybody very much for the preparation, the thought, the dedication, the professionalism and the determination that has brought you here, your involvement, your engagement. And I pray that you will continue to be sustained and engaged with self-care and delight in your social work colleagues and opportunities to be meeting, sharing, reflecting, growing and learning together with such wonderful, wise, competent, beautiful people. So thank you very much for this wonderful opportunity today, and we look forward to being with you again tomorrow.
Thank you, ma'am.
Thank you, everybody.
Thank you. Thank you. Bye for now. Thank you.
Special thank you to the chairpersons of today, Dr. Srinivasa Murthy, and Ms. Naomi Spencer for leading today's session effectively. Thank you also to the speakers from Asia and Pacific for your contributions. I hope the participants have learned something new from these continents. Participants, we apologize. Due to time constraint, most of the questions that were asked on YouTube could not be answered. We have come to the end of day 2 of the international webinar on global trends in mental health. Before we close, tomorrow's session will begin at the same time as today, 3 p.m. Indian Standard Time. Hope to see you all tomorrow. Please fill the attendance link that is shared at the Zoom and YouTube chat box before you leave. Thank you all. Have a good evening.
Thank you.
Thank you, Shiva, for your wonderful
Thank you. Bye, everyone. Thank you. See you, Naomi.
Thank you very much.
Thank you, Armando. Thank you, Naomi.
Yeah, thank you, everybody.
Thank you,
Wonderful
Pamela.
job today.
Thank you.
See you tomorrow.
Yeah.
Yes,
See you
and thank you
tomorrow.
everyone for the wonderful technical assistance and
you.
support and advice regarding our answering those questions. Anyway, until tomorrow.
Thank you, Naomi.
Thank you, Naomi. It was very good.
Yeah.
Very nice session.
Thank you very much. Bye-bye. It's good night here.
Oh, okay.
Sleep in the night for you.
Yeah, it's raining in Chennai.
Bless you.
Okay, hope to see you tomorrow.
Thank you, Prince. Thank you, Sylvia.
Thank you, sir. It was wonderful to share a session with you.
Thank you.
Srinivas,
Thank you, sir. Thank you.
Everybody.
Srinivas Murthy is still here. Thank you, Dr. Srinivas Murthy, sir. It was wonderful to be with you. Okay.